Good morning, everybody. It's a pleasure to be here in this course action, and I thank you, the organizers, for thinking I could share my thoughts on response monitoring in vivo using preclinical models and using for this metabolism, which means to me spectroscopy. Even that most of us working in preclinical models, we hope to be translational sometime. So this means helping clinicians that use the gold standard, which is still the top treatment scheme, which means you operate patients, surgery, and then you check whether this was good enough, perhaps supramaximal, with an early MR exploration, and then you wait until patient recovers between 2-4 weeks, and then you apply concomitant radio and chemotherapy for about 6 weeks, and then you check again with MR about 1 month after that, and administer adjuvant temozolomide alone during.
Hello, can you maybe use a microphone and the people in the back can hear you better?
I was told not to use it, but all right. So, is it better now? Yeah, all right. And then you repeat this in 5-day cycles, once per month, about that. And you check every 2 months' time. And that's where, hopefully, we could help them devising better strategies for following this relapse in case it is presented. MR usually uses the random response assessment criteria for that on images. And then let me have a spoiler, even that I'm going to show you preclinical stuff. There has been work by Margarita Julia Sapé, formerly an associate in my group, collaborating with clinicians Albert Bice, which has been producing what we think is a biomarker for pseudoprogression, so transient response at 1 month after ending the concomitant radiotherapy, showing that contrast enhancement. Of course, if you wait for 2 months, you are going to see that this does not increase, so this is pseudoprogression, but if you use spectroscopy, here you have the pulsated fatty acids that Arús was talking about in the previous first talk, and you image that, you find that patients showing this predominant, let's call source, are predicted to show pseudoprogression, and indeed this is confirmed 2 months later, while if they show this other pattern, proliferating tumor, colored in red, at 1 month after ending concomitant radiotherapy, 2 months later, tumor grows, so this was true progression. And if there is time at the end, I will get back to that. But for thinking that we understand and believe those results, we have needed preclinical model work. 20 years of this, we are slow. And this is a younger Ruiz Simoes, 20 years before, in his PhD at UAB, and he proposed for use the GL261 cell model, which is somewhat old, developed about 90 years ago, which when injected stereotactically into C57BL6 mice in their striatum grows and behaves as a syngeneic model. All spectra and images that we're going to see, preclinical ones, have been acquired at 7 Tesla in a Bruker horizontal system with PRES or CSI PRES sequences, providing a nominal slice resolution of about 150 micrometers and anisotropic in 1 millimeter slices, and being acquired with an echo time between 12 and 14 milliseconds for short echo time, and at 136 for long echo time, and acquisition total times between 5 minutes for single voxel and 21.5 minutes for multi-voxel per slice. The tumor evolution was easy to follow by T2-wasted MRI. Even at day 3, you would see very small dot, very small tumors below 1 cubic millimeter that would grow in 3 weeks' time to about 200 cubic millimeters. This was very reproducible, 100% penetrance, and this would kill animals by volume effect in about 3 weeks. Of course, we had the model, we thought this was useful for us, but then we needed therapies that would produce transient response to then develop a biomarker. This took some willing and dealing, and this was the PhD by Teresa Delgado Goñi, inspiring previous work, and this was the temozolomide protocol that would work for us, 60 milligram per kilogram, 10% dimethyl sulfoxide, oral administration. And the 522 protocol means 5 temozolomide days, 1 dose every day, 3 days rest period, 2 days therapy again, 3 days rest period, and again 2 days of therapy and then monitoring. And this did produce, with respect to control tumors, transient tumor growth arrest with significant differences for tumor volume, which by this bought us time, about 10 weeks of time in the Kaplan-Meier survival curve for developing biomarkers, which were MRS-based biomarkers in our case. And for this, we investigated metabolomic differences in the pattern between control and responding GL261 GB tumors. This was again the work by Teresa Delgado Goñi with a cohort of mice, a training group with treated and control animals, a test group to evaluate the developed biomarkers, an independent test group, and the idea was use single and multivoxel, and this is essentially shown for multivoxel, acquire patterns, and then process those patterns to develop a classifier that would recognize and color code normal tissue from untreated control tumors from responding tumors. And in this first approach, these features were selected by sequential forward feature selection. The selected features, this means individual peak heights or point heights, were processed with linear discriminant analysis, and from this, a classifier recognizing normal brain, untreated tumors, and transiently responding tumors was developed, and then this could be used to color code individual pixels in an MRSI image, producing a nosological-like image of response, green. Of course, the goodness of the classifier was tested in the training set. We could approach 95%, but then you could overtrain, and this was evaluated with the independent test set, showing that it was safe to stop at 12 features. These were the chosen features by the model, which essentially correspond to individual data point heights that can easily discriminate normal tissue versus tumor, acetyl aspartate and total creatine, or responding from control tumors. And these were black mobile lipids, apoptotic mobile lipids, the PUFAs that Haris Koptani mentioned, and these were the measured therapy response biomarkers. And of course, we could then color code control tumors, red, blue, and affected brain, and differentiate them from responding tumors, green pattern for that one. We were then interested in getting it better, in the sense that this LDA was using 12 features. Why not using the whole pattern? We are missing information if we don't use the whole pattern. And for this, we collaborated with the team led by Paul Lisboa, with Sandra Ortega and Ivan Ollier at the Liverpool John Moore University then. And for this, we were using this pattern recognition technique, convex non-negative matrix factorization, CNMF, that uses the whole pattern. The idea is essentially that you have a series of patterns from the different pixel voxel elements, and then we assume that there are sources which are paradigmatic spectra. These are mathematical vectors that belong to different cell types or tissue types. Response, if you are treating, or different cellular patterns, normal brain versus tumor. And this is a matrix that simply provides weights. If you multiply these two matrices, you should be able to reconstruct the original spectra. This provides you the information of what is the most contributing source, and then allows you to assign this to the winning vector and color code it. Then this schematizes that from the several cohorts from which we acquired MRSI and had treated, this was then used to extract label for learning a training data set with quite a stringent selection, so that we chose, let's say, the clear-cut control cases, the clear-cut transiently responding cases, and then we were also very stringent in the sense that voxels in the outer part of the grid were not used because of log signal to noise, and also close to the limits or the borders of the tumor were not used, just to train with the best spectra. Of course, once the classifier is developed, it can be applied to the whole mass. And then 3 paradigmatic sources were robust and extracted: normal brain, control tumors, or not. Use the weighting matrix to apply to nuancing cases, to test cases, and then decide whether they are responding or not. These 2 sources from the control and responding spectrum may look similar to you. They are similar, but they're not the same. These are not spectra, these are mathematical sources. And then you can see that if, for example, you look at the polyunsaturated fatty acids region, this is a 4-fold increase. And indeed, everything changes: mobile lipids and lactate, glutamine, glutamate, glycine regions, alanine, everything changes. Everything is different, but then we're using all of these, sometimes minor difference, 10, 20%, 50%, 4-fold, we use everything. And then we color code in the growth curve of different cases. So we're quite happy to see that control tumors, or tumors at the start of therapy, would be colored red, and the tumors that would respond, some green, would appear. But then, of course, when the growth would arrest, they were seen green. So the pattern, the metabolomics, the source was the responding one, and also for this other one. But when the tumor would relapse, red would appear again. So we thought we were understanding, and we had the biomarker. But then we know, glioblastomas are heterogeneous. And then perhaps we said, well, this was single slice studies for the MRSI. Why, if we try, what would happen if we try to look at the whole volume? This was work by Nuria Arias Ramos at her PhD, supervised by Ana Paula Candiota. This was the initial set of studies, the middle slice, but then we moved to increasing the number of slices between 3 and 4, color coding in the usual way, and then we devise kind of a quantitative index, the TRI, the tumor responding inch, simply dividing how many responding tumor pixels green with respect to total tumor pixels, green plus red. And the assumption was clear: the higher the TRI, the better, or the higher the therapy response. Well, we didn't expect what we saw, but that's what we got in the next cohort. This is just one case, but it's a paradigmatic one. So 522 protocol, no significant change in tumor volume during about 10 days, but then you go for the metabolomics pattern. The patient is responding, the patient is not responding, the patient is responding, the patient is not responding again. So we did not understand a thing, and we went to the literature, because this was cycling about 6 days. 6 days. Does this mean something? Thanks God, somebody else had been working on this, not on imaging, but on the model. This was work by Wu and Baxman, a series of works at Boston, States, using subcutaneous GL261. It's not the same, as you know, using cyclophosphamide as chemotherapeutic, not temozolomide, but still the results were so good to us. I mean, they were curing those mice from the tumor, the subcutaneous tumor, in a few days by using metronomic called therapy every 6 days. Temozolomide every 6 days. It wouldn't work with 3 days, wouldn't work with 9, but it worked only with 6. The mice were cured from the tumor, and even more. Re-challenge on the other side, they did show 2/3 immune memory, and they did show that the immune system was involved. So then, others had been also walking along this path. Melman in a review and others had been calling our attention into this immune system tumor response situation, and that's simply what's called, or dubbed by them, the cancer immune cells cycle. So you hit the tumor with therapy, any therapy. You damage cells, you kill, or you simply damage. These cells release signals. This calls the antigen-presenting cells, dendritic cells, macrophages, which digest what's in here, expose peptides, travel to the ganglia, the lymph nodes, and then they prime naive lymphocytes. This takes 2 or 3 days, and they travel back to the tumor through the blood. And then they produce the effect, the cytotoxic effect. This takes between 6-7 days. That's the explanation, that's the origin of this 7-cell cycle. You do not want to hit your tumor when the lymphocytes are being amplified, chronally amplified with systemic therapy. You need to spare them. So you just hit once every 6-7 days. So to avoid confusion with the original, more classical metronomic significance, which means regular therapy at low dose, we kind of change it, and we simply, it's easy to use this acronym, IMS, meaning for us, immune system respectful, so we don't hit the amplification time, metronomic therapy administration schedule every 6 days. And we added for biomarker development with MRI, MRSI exploration every 2 days. So that was the protocol. If we had understood it properly, when using this in our system, we should generate response and also cycling. So we started therapy at 11 days, established tumors every 6 days, and explore the mice every 2 days with MRI, MRS. And God behold, it did work. That was work in the cities of Xuangwu, supervised by Ana Paula Candiota. This was the original 5-2 survival curve, and this was using the IMS therapy. 60% of these mice in that cohort were cured. Well, of course, they were long-term survivors, but they were cured. What else? Excuse me. Something went wrong. Yeah, I regain control. Yeah, all right. So then you had 2 types of growing curves. Of course, where red is the controls, black is the tumors that were cured, but still the volume increase is clear. You had 10 days to follow them up. And you also had the green ones in which there was a transient response, and you had more time, about 1 month for following up. So first part of the question, first part of the answer, therapy was effective. We were also curing these mice like in the subcutaneous ones. And did we have cycles? Yes, we did have. Even for the transiently responding ones, you have 1 through 3, perhaps 4 cycles before, in these ones, they escape. Of course, the ones that were cured, you also had cycles, but you just had time to see 2 of them. And once there was tumor volume change, you could re-challenge them in the contralateral hemisphere, and then in this particular instance, 100% of the animals did not show tumor growth, so they were cured. So that means immune memory, 100% of the animals. And what's more interesting for the biomarker development, the control animals, and the good ones, were always red or slightly green at the end, but they never show cycle. So the biomarker is not just the pattern, it's the cycling of the pattern. So this was also in line with the immune cycle length described in literature. So we kind of changed the cartoon a bit. Here you hit the cells, you hit the tumor with a therapeutic agent. The tumor is initially red, but starts to move to green because these tumor damaged cells are emitting signals. So whatever in the immune system is already there, it's going to strike. And then you have the large amplification here 2 or 3 days later, and then this migrates back. And when the whole wave of amplified lymphocyte reaches the tumor, that's when this is fully green. But remember, these are cycles. This means that 1 or 2 days later, the tumor starts to grow again, starts to be red again. So we did see TRI oscillations for IMS temozolomide, but we also saw and reported oscillations for cyclophosphamide, so the one used by Baxman, for anti-PD-1, and for combined temozolomide and anti-PD-1. So the message here, as you are going to see, is that those changes in the pattern and in the cycling are not actually associated, at least for these therapeutic agents, to the therapeutic agent, but to the type of response you are calling, to the immune system response. That's our proposal. Using the anti-PD-1, it's complex. It's complex in the sense that unless you are careful, you may decide, hey, this is not working. So if you follow the literature, there are certain proposed doses and certain timing times for administration. You have to be careful. If you go to the usual size that we were using, 11-day tumors, so about 8-9 cubic millimeters, these would be the ones you are going to see. It is small, but clearly seen. So this is the metronomic protocol for anti-PD-1. And then what you would conclude here is that anti-PD-1 is not working, is not curing large tumors, which is a fact. But then if you go to the small ones, they get cured with immune memory. Conclusion out of this, the initial tumor volume is relevant. And whenever you are going to compare results with the literature, you have to take this into account. These are the up and down of the tumor volumes. And of course, you could do it better. You can cure established tumors if you use combined, which is the blue one, anti-PD-1 and temozolomide. Then you can deal with the large ones, but not if you use anti-PD-1 alone. Of course, fortunately for us, you see cycles. Just one, because those tumors respond so fast, you just have time to see one cycle, but you see cycles. How do we try to explain that? What is the explanation for the existence of the pattern and of the cycles from our perspective? This has been worked by Pilar Calero, Nuria Arias, and Xuan Wu, supervised by Ana Paula Candiota. So it's the microenvironment. That's what you have inside your voxels, inside your pixels. The type of cells, how are they affected? This is what is leading to red or to green. That's what we think. What proof do we have? Let's look at the pattern. PUFAS, this fourfold change. We didn't discover that. As Harris Poptani reviewed, this was already described by Kakumaki, Poptani, Opinion, and others. And this glioma therapy using anciclovir, this increase in PUFAS attributed initially to the apoptotic cells, which I do believe was already seen. But you do not need to have a tumor to see that. This is the resonance, the methylene between two vinyls of polyunsaturated fatty acids in triglycerides in lipid droplet inside cells. But that they can be inside different cells. I mean, this is stroke. Stroke in a rat 7 days after middle cellular artery ligation. And these are the patterns for that region and for the contralateral region. ML3 is the PUFAS, large one, fully absent in the contralateral. This is just aspartate from N-acetyl aspartate. So what are those? Dying neurons. Well, other people have investigated this, and these are the Nile rat stain droplet inside macrophages. So rat cells die, but after cells die, the clean system comes, and the clean system are the macrophages. So the lipid droplets can be in different places. Then we did a lot of histopathology. We meaning, for example, the team directed by Martí Pumarola, a neuropathologist at the veterinary school at UAB, doing classical histopathology, 5 micrometer slices, a lot of them, a lot of fields counted on the microscope by eye. I know that's not the modern stuff, but can be done. And then we did obtain numbers. Caspase-3, so apoptosis, did increase with tumor response. K67 proliferating cells did decrease with tumor response. This can be counted. Lymphocytes, CD3 positive lymphocytes did increase. I know there's a lot of overlap, 1.5-fold increase on lymphocytes with response. Red is always response. 2.4-fold increase for the IBA1 immunohistochemistry marker, which stains for microglia macrophages, increase in the response. And also, if you have a look at the traditional eosin hematoxylin stain, this would be a control tumor, a lot of 20 micrometer cells proliferating, GL261 cells. But then when tumors respond, and of course we know the index of response because you had the in vivo before, different cells appear, multinuclear, very large cells, larger than 100 micrometers, and
Only 1 minute.
gosh, fly. Microcystic spaces, acellular spaces do also increase. RT-PCR, macrophages also increase several fold upon response. M1, M2 polarization ratio does increase. PDL1 also increases. Everything is changing. And this is related to the energy stage of lymphocytes. And then this summarizes what is happening. Red tumors, green tumors, everything changes. Acellular spaces, 2.5-fold increase. Tumor cells and other not macrophages, 2.5-fold decrease. Macrophages, about 2.5-fold increase. Lymphocytes increase, but you are not going to see this by MR because it's just 1%. So this different makeup of cells is what is going to change the pattern. And this cycles with time. The volume may not change. You may not change in volume, but you're going to see cycles. And these cycles originate because cellular spaces, microcystic volumes, tumor proliferating cells, macrophages of them one type do oscillate in days time. I will have time to deal with the clinics of this, just mention that but we know how to get better. And let me just thank people in the group or formerly in the group providing slides, Margarita Juliana, Paula Candiota, Carlos Majors, and you for your attention. And I'm happy to address questions.